The liver is the largest internal organ in the body, located in the right upper quadrant. Blood supply to the liver comes from the hepatic artery, which supplies about 1/4 of the blood, and the portal vein, which supplies 3/4 of the blood. The portal vein carries absorbed products of digestion directly to the liver. The liver is an essential organ for life as it functions in the manufacture, storage, transformation, and excretion of a number of substances involved in metabolism. Understanding the normal functions of the organs will help you to correlate the signs, symptoms, and complications patients experiencing dysfunction of that organ may exhibit. So with the liver, the metabolic functions include carbohydrate metabolism. This includes conversion of glucose to glycogen, the process of breaking down glycogen to glucose, and formation of glucose from amino acids and fatty acids. Protein metabolism is the synthesis of clotting factors, urea formation from ammonia. Ammonia is formed from deamination of amino acids by action of bacteria in the colon. The deamination is the process by which amino acids are broken down if there is an excess of protein intake. The amino group is removed from the amino acid and converted to ammonia. This is going to be important when we start talking about cirrhosis of the liver. Another function of the liver is detoxification. This is inactivation of drugs and harmful substances and excretion of their breakdown products. Storage functions include glucose in the form of glycogen, vitamins, which include fat-soluble and water-soluble, minerals, including iron and copper, and amino acids in the form of albumin and beta-globulins. A hematology role is done by the Kupffer cells in the liver. It is the breakdown of old red blood cells, white blood cells, and bacteria mainly. The breakdown of hemoglobin from old red blood cells to bilirubin and biliverdin is performed. Disorders of the liver that we're going to discuss include hepatitis, which is an inflammation of the liver mostly caused by viruses, liver disease, which is any condition that damages the liver and prevents it from performing its functions, cirrhosis of the liver, which is a chronic progressive disease characterized by the extensive degeneration and destruction of the liver parenchymal cells, and liver failure, which is characterized by a rapid onset of severe liver dysfunction. Viral hepatitis is a major health problem in the United States. All are clinically similar but have different causes. Hepatitis A, also known as HAV, is transmitted primarily through the fecal-oral route by ingestion of food or liquid infected with the virus. Poor hand hygiene, improper food handling, crowded situations, and poor sanitary conditions are all factors related to Hep A. Transmission occurs between family members, institutionalized individuals like prisoners, and children at daycare centers. Outbreaks occur via foodborne transmission, usually by an infected food handler. Hepatitis A can cause a mild flu-like illness or acute hepatitis with jaundice. It does not result in long-term chronic infection. There is a hepatitis A vaccine recommended for at-risk people in children at the age of 1 year. At-risk people could include somebody that has eaten at a restaurant where a worker has been diagnosed with hepatitis A. Hepatitis B, also known as HBV, is transmitted through blood or body fluid exposure. It can be transmitted perinatally by mothers infected with hepatitis B, horizontally by mucosal exposure to infectious blood products, or other body fluids, percutaneously via needle sticks or IV drug use. Hepatitis B can live on a dry surface for at least 7 days. Hepatitis B can cause either acute or chronic disease. In the majority of patients with acute hepatitis B, the infection completely resolves. Of those that develop chronic infections, the liver impairment can range from a normal liver to severe liver disease, and 15 to 25% of people who are chronically infected will die. There is a hepatitis B vaccine. It is a series of 3 injections. It is completed in children by the age of 6 to 18 months. It is recommended for adults in at-risk groups, such as healthcare workers, and those with chronic kidney disease before they begin dialysis. There is also a post-exposure prophylaxis that is used in patients that may be exposed, like those that get needle sticks that have not been given the Hep B series. Hepatitis C, also known as HCV, is primarily transmitted percutaneously. The most common mode of hepatitis C transmission is needle sharing. Other risk factors include transfusions prior to 1992, high-risk sexual behavior, occupational exposure, and hemodialysis. Hepatitis C can result in both acute and chronic illness. Acute Hep C is usually asymptomatic and can be difficult to detect unless lab studies are completed. The most common causes of acute hepatitis C are injection drug use and outbreaks among HIV-positive homosexual males. The majority of people who acquire hepatitis C usually develop chronic infection and are unaware that they have it. 20 to 30% of chronic hepatitis C patients will develop cirrhosis. Chronic hepatitis B and hepatitis C account for 80% of the cases of hepatocellular cancer. About 30 to 40% of HIV-infected patients also have hepatitis C, and this is primarily related to IV drug use. Co-infection of HIV and hepatitis C puts patients at greater risk for disease progressing to cirrhosis. So when we're talking about acute hepatitis, that usually lasts less than 6 months with the return of normal liver function, or it progresses to chronic hepatitis. Chronic hepatitis is an inflammatory process that lasts longer than 6 months and may also progress to cirrhosis and possibly liver failure. There is slight variation in manifestations among the types of hepatitis. In acute hepatitis, many people have no symptoms. Many chronic hepatitis people are also asymptomatic. The acute phase of hepatitis, which typically lasts 1 to 4 months, is the time when people are most infective. Acute manifestations include being anicteric or icteric, meaning they may or may not have jaundice, fatigue, malaise, some not having the energy to accomplish activities of daily living. They may have anorexia or flu-like symptoms such as fever, chills, weight loss. They may complain of right upper quadrant pain, nausea, and occasional vomiting. People may have dark urine from excess bilirubin being secreted. They may complain of pruritus, or intense itching may accompany those with jaundice, and this is due to an accumulation of bile salts beneath the skin. The convalescent phase, or recovery, begins as jaundice fades and lasts 4 weeks to months. The main complaint during this time is malaise and being easily fatigued. Diagnosis is made by the presence of viral antigens or subsequent development of antibodies found in serum lab testing. Patients are typically sent home and managed there. Treatment of acute viral hepatitis consists of rest with activity as tolerated, nutrition with a well-balanced diet that the patient can tolerate with possible vitamin supplements of B complex and K, and hydration. Rest reduces the metabolic demands on the liver and promotes regeneration of the liver. Adequate nutrition and rest seem to be the most beneficial for healing and liver cell regeneration. There are a few drugs available for chronic hepatitis B and hepatitis C that are in your book. The goal is to decrease the viral load, decrease the liver enzymes, and to decrease the rate of liver disease progression. Long-term goals are prevention of cirrhosis, liver failure, and hepatocellular cancer. Remember, avoidance of alcohol and drugs that are excreted through the liver are other educational topics. Pharmacologic interventions for hepatitis. There are hepatitis vaccines, which mean to protect against, so hepatitis A and hepatitis B. There are no vaccines for hepatitis C. If you're exposed to hepatitis A, there is an hepatitis A immune serum globulin. It must be given within 2 weeks of exposure, and you should also have hepatitis B immunizations initiated. If you've been exposed to hepatitis B, there's an immunoglobulin for that as well, and that should be received within 7 days of exposure and initiate the hepatitis B immunization. Corticosteroids are given to some people to reduce inflammation. Vitamin K, as it says, is given if the PT is prolonged. Some patients also receive antiviral medications. Drug therapy for chronic hepatitis B and hepatitis C are focused on decreasing the viral load and liver enzymes, as well as the rate of disease progression. Long-term goals are the prevention of cirrhosis, liver failure, and hepatocellular cancer. The drugs work on suppressing the viral replication of the virus. In addition, patients can also receive supportive drugs for symptom relief. Prevention of hepatitis A includes hand washing, proper personal hygiene, and immunization. If a person is exposed to someone with hepatitis A, for example, eating at a restaurant where a food service worker is positive, or living in close proximity with another person who has been exposed to hepatitis A or is diagnosed with hepatitis A, immune globulin should be obtained within 1 to 2 weeks after exposure. It is not necessary, say you are delivering food to a patient with hepatitis A, it is not necessary to get the prophylaxis. Prevention of hepatitis B and hepatitis C includes continued screening of donated blood, use of disposable needles and syringes, safe sex practices, hand washing, avoid sharing toothbrushes and razors, healthcare workers' use of infection control precautions, reducing contact with blood and body fluid exposure, and use of needleless IV access devices when available are all good precautions. For hepatitis B, also vaccination is another thing that you can do to prevent getting hepatitis. Nursing management and nursing interventions for viral hepatitis will be something that we are going to discuss in class. So think about what I've gone over here, and think about the different things that you may use as nursing interventions in the care of this type of patient. So there are a few different liver diseases. One is drug and alcohol-induced liver disease, which we're going to talk more about. There's autoimmune liver disease, or also known as autoimmune hepatitis, which is a chronic inflammatory disorder that does not have a known cause. There's genetic liver diseases, one being Wilson's disease, which is a defect in the transport of copper. There is hemochromatosis, which is a disease of having an overload of iron. There's also non-alcoholic fatty liver disease, which refers to a wide spectrum of liver diseases that range from a fatty liver to cirrhosis. Then there's chronicity of liver disease. Acute, which lasts less than 6 months with a return of normal function, or it progresses to chronic liver disease. Then we have chronic liver disease, which is lasting greater than 6 months, which may progress to cirrhosis and possibly to liver failure. Alcohol consumption is a frequent cause of both acute and chronic liver disease. It can cause a spectrum of symptoms ranging from mild elevation in liver enzymes to acute alcohol hepatitis to acute alcoholic cirrhosis with end-stage liver disease. It is often undetected until the patient presents with symptoms of decompensated cirrhosis, which we'll talk about in a little while. Treatment is abstaining from alcohol, which may improve the symptoms, actually not abstaining, but cessation of alcohol, along with supportive measures to reduce the risk of mortality from complications of liver disease. Medications can also cause liver disease, and liver injury and death may occur after this happens. It could be some inhalation meds that you get from anesthesia. It could be parenteral injections or ingestions of certain drugs. Prescription drugs include sulfas, thiazides, statins, amiodarone, acetaminophen, that are prescribed in many medications such as Vicodin or oxycodone or OxyContin. So when you're giving these prescriptions to patients, you have to make sure they understand that it has Tylenol or acetaminophen in it, so they should not be taking those over the counter in addition to the medications that they're taking. So signs and symptoms that you may see with patients that are having drug-induced liver disease include the jaundice, low-grade fever. They may complain of flu-like symptoms, joint pain. They may have dark urine, like we discussed with hepatitis, and then they'll start to become yellow or jaundiced, and we need to pay attention to this because we don't want them to go into acute liver failure. Complications of liver disease or hepatitis include liver failure. Acute viral hepatitis can occasionally result in severe impairment or necrosis of liver cells and potential liver failure. Liver failure can also come from drug or alcohol-induced liver disease. Chronic hepatitis, as I said previously, can be induced by hepatitis B or hepatitis C. Approximately 75 to 85% of patients who acquire hepatitis C, and many with hep B infections, will go on to develop chronic lifelong viral infection. Cirrhosis of the liver is a result many times of alcoholic liver disease, but it also can come from chronic hepatitis C, can cause cirrhosis of the liver. These can all lead to the complication of hepatocellular carcinoma because of the changes in the liver cells. Abnormal liver function is usually not apparent unless a significant acute insult occurs or chronic liver disease is fairly advanced. Cirrhosis is a chronic progressive disease characterized by extensive degeneration and destruction of the liver parenchymal cells. It is an insidious, prolonged course, usually after decades of liver disease. The cause most frequently in the United States is alcohol-induced liver disease and chronic hepatitis C. Chronic hepatitis combined with alcohol ingestion is synergistic in accelerating liver damage. Malnutrition, which sometimes is secondary to alcohol intake, decreased protein, extreme dieting, malabsorption, or obesity. Heart failure. When I talk about heart failure, right-sided heart failure that can cause cirrhosis, this is long-standing, severe right-sided heart failure. In cirrhosis, the liver cells attempt to regenerate, but the process is disorganized, resulting in abnormal rebuilding of blood vessels and bile ducts. This results in impeded blood flow, poor cellular nutrition, and hypoxia from inadequate blood flow and scar tissue, resulting in decreased functioning of the liver. Clinical manifestations of cirrhosis. The early manifestations are really consistent with a lot of fatigue. The onset is insidious. Many patients with normal liver function, which is compensated cirrhosis, may not even be aware of their liver condition. The diagnosis may not be discovered until later when they manifest symptoms of more advanced liver disease, which can include jaundice, peripheral edema, and ascites. The really advanced cirrhosis, the liver becomes small and nodular. Later clinical manifestations that you may see in patients with cirrhosis, many of them are typical. You can see changes in mental responsiveness and memory. This is related to increased ammonia levels. Jaundice occurs as a result of the decreased ability to conjugate and excrete bilirubin. Spider angiomas in the face, neck, and shoulders, as well as on arms possibly, and on the chest. This is dilation of the arterioles. You may see esophageal varices. This is because blood backs up in the portal vein and has to do with the portal hypertension, just like the hemorrhoids. Hepatomegaly and splenomegaly are all caused by portal hypertension. Anemia, thrombocytopenia, and coagulation disorders related to the inadequate blood cell production. Palmar erythema, you may also see this on the soles of the feet, and this is related to increased estrogen levels. Ascites develops gradually, and it's an accumulation of serous fluid in the peritoneum. Peripheral neuropathy, and this is due to a dietary deficiency of B complex vitamins. The edema may be caused by endocrine disturbances because the failure to metabolize aldosterone, which makes for hyperaldosteronism, and patients will have increased sodium and water retention. And in addition, they'll also have potassium loss. Complications of cirrhosis that we're going to talk about: portal hypertension, which is a cause of esophageal and gastric varices; peripheral edema, ascites; hepatic encephalopathy, hepatorenal syndrome. So understand that patients without complications of cirrhosis is compensated cirrhosis. Your body's still compensating. Patients with more than one complication of their liver disease is decompensated cirrhosis. Structural changes in the liver cause obstruction to the normal flow of blood through the portal system, resulting in portal hypertension. Portal hypertension is characterized by increased venous pressure in the portal circulation, splenomegaly, large collateral veins, ascites, systemic hypertension, and esophageal varices. The collateral circulation develops in an attempt to reduce increasing portal pressure, and these form in the lower esophagus, anterior abdominal wall, and parietal peritoneum in the rectum. This is where esophageal varices, gastric varices, and increasing hemorrhoids come from. Portal hypertension results in collateral vessels in the upper stomach and esophagus, as I had said. Vessels are thin-walled and fragile. They can be damaged with any increase in intra-abdominal pressure from coughing, sneezing, vomiting, straining, or ingestion of rough food. Patient may present with melena or hematemesis. There may be a slow oozing or a massive hemorrhage. It is considered the most dangerous complication of portal hypertension. There's a 50% mortality rate with bleeding esophageal varices. The patients that have been diagnosed with esophageal varices are monitored by periodic endoscopy. There are several treatments for esophageal varices. One is using endoscopy, putting a small rubber band around the base of the varice. Also sclerotherapy, which is an injection of a sclerosant into the varices with a needle placed through the endoscopy, and it develops into a clot on the wall. There's also the Sp17 Blakemore tube, which we're going to talk about in a minute, and that's for more major bleeds. And the TIPS procedure. The TIPS is transjugular intrahepatic portosystemic shunt. And it's a non-surgical procedure where the tract between the systemic and portal venous system is created to redirect portal blood flow. A radiologist places a catheter in the jugular vein and then threads it through the superior and inferior vena cava to the hepatic vein. The wall of the hepatic vein is punctured and the catheter is directed to the portal vein. Stents are positioned along the passageway, overlapping in the liver tissue and extending into both veins. This procedure reduces portal venous pressure and decompresses the varices, thus controlling the bleeding. The procedure usually lasts 1 to 3 hours, and the patient is usually hospitalized for 1 to 2 days after the procedure. The TIPS procedure usually controls bleeding immediately in over 90% of the patients. The Sp17 Blakemore tube is used in emergent situations or if we're waiting to go to endoscopy and we have an immediate bleed. There is an NG tube, there's 3 lumens, an NG tube that drains the stomach of blood, a gastric balloon that will be blown up to a specific pressure to decrease blood flow to the esophageal varices, and this can be used usually 48 to 72 hours. There's also an esophageal balloon that can be used for up to 24 hours. Traction will be applied in like a pulley system with about a 500 cc bag of saline, pulling it because you need to keep traction on the gastric balloon against the varices to try to keep the bleeding in check. Things that you have to do for nursing to be sure for safety of the patient: head of bed elevated to semi-Fowler's or 45 degrees. Traction needs to be maintained. The big thing is monitoring airway, because if the tube migrates, it can asphyxiate the patient, so you need to have scissors at the bedside to be able to cut the tubing in case the balloon moves. Monitoring for skin breakdown at the nares where the tube goes in. These patients are typically very ill if they need a Blakemore tube, so they may be vented. They need mouth care every 1 to 2 hours. Respiratory assessments for their airway are extremely important. Ascites is the accumulation of serous fluid in the peritoneal or abdominal cavity. It is a common manifestation of cirrhosis. When the lymphatic system is unable to carry off the excess proteins and water, they leak through the liver capsule into the peritoneal cavity. The osmotic pressure of the proteins pulls additional fluid into the peritoneal cavity. These patients are at increased risk for a spontaneous bacterial peritonitis, an infection of the ascites fluid that you have to keep in mind. Manifestations include abdominal distension, signs of dehydration, decreased output. Hypokalemia is also very common. Management of these patients includes sodium restriction based on the amount of ascites they have, but encouraged intake is less than 2 grams a day. Patient is not usually on restricted fluids unless severe ascites has developed. You need to make sure that you're accurately assessing and monitoring fluid and electrolyte balance. Albumin infusion may be used to help maintain intravascular volume and adequate urine output by increasing plasma colloid osmotic pressure. Diuretic therapy diuretic therapy is very important. They typically will use a few different types that work on multiple sites in the nephron because that is more effective. So you may often see these patients on potassium-sparing diuretic as well as a loop diuretic. Another management is paracentesis. That's a needle puncture of the abdominal cavity. It's typically reserved for patients with impaired respirations or abdominal pain caused by severe ascites. It's only a temporary measure because fluid tends to reaccumulate. They will put the needle in to drain the acidic fluid, and it's emptied into a glass vacutainer bottle. It typically takes off a few liters, but it could be up to 8 liters. Problems that could, or complications that can happen afterwards include fluid leak or bleeding. Also bowel perforation or lung collapse. One of the main things you want to make sure that you have your patient do prior to going to get a paracentesis done is to make sure that they empty their bladder. Very important. Hepatic encephalopathy is a terminal complication of liver disease. It's caused by the inability of the liver to remove toxins from the body, but mainly ammonia. Manifestations can start subtly and include changes in memory and progress. So early signs of hepatic encephalopathy include patients having faraway looks with a slowed thought process. They may have irritability or insomnia with a slowed affect and show confusion and forgetfulness. They may demonstrate impaired judgment, slurred speech. They may have a slight tremor, and their ammonia may be slightly elevated. A next stage could be those with an impending coma. They may demonstrate disorientation, be incontinent, have bizarre behaviors and ataxia or decreased muscle coordination. They may demonstrate apraxia tremors, which are intention tremors. That means the tremors are intensified when the person is trying to accomplish something, and an inability to perform purposeful movements. Another manifestation these patients may have is asterixis. Remember, this comes later. You can click on the asterixis demo link, and that will show you a little video. There's irregular flapping movements of the fingers and the wrists when the hands and arms are outstretched. This is associated with jerky muscle tremors. It could also be in the feet and the tongue. This is called a liver flap or a tremor when this happens with their hands. And remember, this is a later manifestation. Another thing these patients may demonstrate in the later stages is fetor hepaticus, which is bad breath. It's a peculiar, sweet, musty odor. It could be an acetone odor like freshly mowed grass or old wine, and this is due to an accumulation of toxins in the blood that are being let out through the lungs, so they have that breath. Their ammonia levels are going to be increased. The next stage would be stupor, which would be a deep sleep, but they may be arousable, they may have incoherent speech, and their ammonia level is going to be even more elevated. The last stage of hepatic encephalopathy would be coma, and they would respond to painful stimuli, or there may be no response with decerebate positioning. Their ammonia levels are going to be grossly elevated. You need to remember that ammonia crosses the blood-brain barrier, and this is what produces the neurologic toxic manifestations that these patients demonstrate. The liver is no longer able to convert ammonia to urea, so the levels are increased. So this is just a picture showing what happens with hepatic encephalopathy. These changes happen because we have increased ammonia in the blood. So remember, ammonia is primarily from digestion of protein by bacteria in the intestines, which is typically processed by the liver. So what you see is a change in neurological and mental responsiveness or impaired consciousness. It can start with progressive confusion. Some are stuporous. Neuromuscular disturbances also happen. Remember, asterixis is a late sign. Problems are increased by increased protein because of it's not being processed by the liver properly. Infection because we have increase in catabolism and brain sensitivity to toxin. The problem can be increased by hypovolemia, because then you have increased ammonia related to hepatic hypoxia and decrease in blood flow. Also, hypokalemia can increase the problem because you have increased ammonia and the potassium is needed for the brain to metabolize that ammonia. GI bleeding can increase ammonia in the GI tract related to the protein digestion. So treatment for hepatic encephalopathy includes decreasing the protein in the diet, giving lactulose, because lactulose creates an acidic environment that favors the production of non-absorbable ammonium ion over ammonia, which is easily excreted. Lactulose also induces frequent bowel movements to help excrete the toxins. I know this slide says neomycin, but neomycin is an aminoglycoside and it's known for causing ototoxicity and nephrotoxicity. So it has been limited as a first line use in hepatic encephalopathy. You may see it on NCLEX, but you need to know it's no longer used as the first line antibiotic. What is used with lactulose is rifaximin, Rifaximin. It's poorly absorbed and has a low incidence of bacterial resistance, so it is more often used now. What it does is it stops the growth of the bacteria that produces the toxin that worsens hepatic encephalopathy. So, treatment: decrease protein in the diet, lactulose, and rifaximin. In acute liver failure, also known as fulminant hepatic failure, the typical causes are from drugs, usually Tylenol with alcohol abuse. Also includes isoniazides, sulfas, and NSAIDs. Another cause of viral hepatitis, which in particular is hepatitis B, which is the second most common cause of acute liver failure. It's characterized by the rapid onset of severe liver dysfunction in someone with no prior history of liver disease. It can run its course in 8 weeks, but can last up to 26 weeks. In acute liver failure, the changes in mentation are the first clinical sign. Hepatic failure occurs when there is a loss of 60% of hepatocytes. Symptoms are usually detectable after 75% or more of the hepatocytes are injured or killed. These patients will often demonstrate manifestations of jaundice, coagulation abnormalities, and encephalopathy. Frequent complication of liver failure is renal failure, and liver transplant is the treatment of choice for acute liver failure. Lab results that you will typically see with liver dysfunction. Now remember, you don't look at just one level by itself to determine that the patient is in liver failure or has liver disease. Many can elevate or decrease alone when something else is going on, as you know. So labs that we want to look at are the AST and the ALT, which indicate liver cell injury. Ammonia levels will be elevated. The liver typically clears ammonia, but when it is not functioning properly, blood is shunted around the liver, thus increasing the amount of ammonia in the blood. PT and PTT are elevated or prolonged, and this is a result of decreased production of clotting factors. Bilirubin is elevated. The amount the liver can process due to excess breakdown of red blood cells is exceeded. Albumin is low. This is due to decreased synthesis by the liver. Remember, the liver is the body's site for protein synthesis. The hemoglobin and the hematocrit will be low. This is due to decreased production by damaged liver cells. Remember the first slide that we talked about with the functions of the liver? That was why we went over that, so that you can consider these in the process of the disease. Collaborative care for liver dysfunction. There really is no specific therapy for cirrhosis. It's really to prevent and treat the complications that arise with it. patients need to rest. They must avoid alcohol and minimize or avoid use of NSAIDs, acetaminophen. Management of ascites that we discussed earlier, management of hepatic encephalopathy, which we also discussed, and remember the therapeutic goals of varices is avoidance of bleeding and hemorrhage. You can slow the progression of cirrhosis, but you can't cure it. Administering B complex vitamins is also an important collaborative care for these patients. Health maintenance with liver disease is going to include client teaching, discharge planning, special considerations with hepatitis. We're going to discuss these in class, so make sure that you come ready to have discussion, fill out form, or have group discussion, and be able to fill in the blanks. After reading this assessment, what are your initial thoughts about this patient? What do you need to worry about and think about with this patient? What are going to be your priorities? What do you think the physician is going to order for this patient? In other words, what do you expect in the way of care for this patient? Make a little list, bring it with you to class. We're going to discuss it. As with your initial assessments, what are you thinking? What's happening? What treatments is the physician going to do? What are your nursing priorities? Again, we're going to talk about this in class. Please bring your thoughts with you. Pancreatitis is an acute inflammation of the pancreas. It affects both men and women equally. The inflammation can actually range from mild edema to severe hemorrhagic necrosis. In the United States, the most common causes are gallbladder disease is number 1, and that's more common in women, and chronic alcohol intake is number 2, which is more common in men. The etiology of pancreatitis. The risk factors in addition to gallbladder and alcohol include smoking, which is an independent risk factor, biliary sludge, which is a mix of cholesterol crystals and calcium salts, and this is found in 20 to 40% of patients. High triglycerides greater than 1,000. Less common causes include trauma, which could be abdominal or post-surgical of on the pancreas, stomach, duodenum, or biliary tract. Viral infections, which could include mumps, Coxsackie virus, and HIV. Metabolic disorders, which could include hyperparathyroidism and renal failure. Drugs, which might include corticosteroids, thiazide diuretics, sulfa drugs, and oral contraceptives. There also can be idiopathic causes, which of course you know is an unknown reason for it. The pathophysiology of pancreatitis is autodigestion, which is when one of the etiology factors we just spoke of injures the pancreatic cells or activates the pancreatic enzymes in the pancreas instead of the intestine. So the pancreas starts to be digested by its own enzymes, which is primarily trypsin. The other pathophysiology of pancreatitis is obstruction of the pancreatic ducts, which results in pancreatic ischemia. And this is usually caused by obstruction of gallstones. Alcohol is thought to be a factor in the patho of pancreatitis, but why it predisposes a person to pancreatitis is really unknown. There are 3 classifications of pancreatitis. First, mild pancreatitis, also known as edematous or interstitial pancreatitis. Severe pancreatitis, also known as necrotizing pancreatitis. This is a severe condition where digestive enzymes destroy healthy pancreatic tissue, which can liquefy the tissue, causing pseudocysts and calcification, as well as development of abscesses. In severe pancreatitis, approximately half the patients have permanent decreases in endocrine and exocrine function. These patients are at high risk of developing pancreatic necrosis, organ failure, and septic complications, and this results in 25% mortality rate. The third is chronic pancreatitis, which typically occurs in patients with a previous pancreatic injury. We'll talk more about chronic pancreatitis, but it is a progressive destructive disease that causes permanent dysfunction. Significant lab results in pancreatitis include an elevated amylase and elevated lipase. This is from pancreatic enzymes being released from the damaged tissue. Elevated glucose due to decreased pancreatic function. Elevated triglycerides related to effects on insulin production, and a decreased or low calcium related to low albumin and calcium binding by excessive fats. Clinical manifestations of acute pancreatitis. Acute pain is the biggest indicator. Pain is the predominant manifestation of acute pancreatitis. The pain is due to distension of the pancreas, peritoneal irritation, and obstruction of the biliary tract. Patients usually complain of the pain with a sudden onset, usually in the left upper quadrant, but it may be in mid-epigastric area. It commonly radiates to the back because of the organ location. Pain is described as severe, deep, and piercing, and it is a constant pain. Pain is aggravated by eating and worse when lying down flat. Vomiting does not relieve the patient's pain. Patients will show abdominal tenderness with guarding. The abdomen could be rigid and have rebound tenderness. Along with abdominal distension, you may have decreased or absent bowel sounds related to hypoactive bowel or paralytic ileus. They may have a low-grade fever or leukocytosis, nausea, vomiting, hypotension, along with tachycardia. They may demonstrate some jaundice as well. Lungs are frequently involved with crackles present, and they are at increased risk for ARDS. More clinical manifestations of acute pancreatitis include ecchymosis, which can be cyanosis or greenish to yellow-brown in color, and this is related to intravascular damage from circulating trypsin. You may see gray-Turner sign, which is flank discoloration, or Cullen sign, which is periumbilical discoloration. And gray and Cullen sign result from seepage of blood stained exudate from the pancreas and may occur in severe cases of pancreatitis. Shock is another thing that we need to worry about. Hemorrhagic shock from hemorrhage into the pancreas. Toxic shock, this from toxemia from the activated pancreatic enzymes, and hypovolemic shock as a result of the fluid shift into the retroperitoneal space, because that retroperitoneal space can take up a lot of fluid, and this would be a massive fluid shift causing hypovolemic shock. Clinical manifestations of chronic pancreatitis include abdominal pain. They may have episodes of acute pain, but is usually chronic pain, which is recurrent attacks at intervals of months or years. Chronic pain is described by people as heavy and gnawing feeling or burning and cramp-like pain, which is not relieved with food or antacids. In the acute attacks, patients with chronic pancreatitis that have an acute attack will complain of the same type of pain as those with acute pancreatitis. Symptoms of pancreatic insufficiency are something else that these patients will demonstrate, which include malabsorption with weight loss, and this is related to the difficulty in digesting fats from the foods. Some people may have constipation. Some may demonstrate mild jaundice with dark urine. This could be related to hepatocellular injury or biliary tract disease. Steatorrhea, which is fatty stools, and this usually appears after losing about 90% of the pancreatic function. And then diabetes, and this is because the pancreas loses its ability to produce enough insulin. Complications of acute pancreatitis include local complications of pseudocyst, which is an accumulation of fluid, pancreatic enzymes, tissue debris, and inflammatory exudates surrounded by a wall. Abscess, which is an accumulation of pus. This results from extensive necrosis happening in the pancreas. Systemic complications include pulmonary complications, which are pleural effusions, atelectasis, pneumonia, and ARDS can also happen. Cardiovascular complications happen from decreased cardiac output, which would include hypotension and effects of hypocalcemia, which is what tetany is from, the hypocalcemia related to increased free fatty acids and malabsorption. Many of the same complications happen in chronic pancreatitis, which includes pseudocyst. It can also have bile duct obstructions, which could cause an abscess, or duodenal obstruction in the intestines, pancreatic ascites, pleural effusions, the same as acute, and pancreatic cancer is also a complication of chronic pancreatitis. Collaborative care for pancreatitis. The goals. The main goal is relief of pain, prevention or treatment of shock, closely monitoring for hyperglycemia. Therapy is focused on supportive care. Hydration is very important. Reducing pancreatic secretions. This is typically done through keeping the patient NPO, especially when they're in acute stage. They may need an NG to suction to reduce any vomiting or gastric distension, and also to prevent acid from entering the duodenum. They may be given drugs to decrease acid production or to neutralize acids. Also, when you're talking about prevention of further attacks, in the diet, pancreatic enzymes replacements may be needed in the chronic patient. Also, diabetes control, if that has become a problem. No alcohol, no smoking, and no caffeine are recommended. Other therapies for pancreatitis, surgical when related to gallstones, an ERCP or endoscopic retrograde cholangioppancreatography, or ERCP, is a specialized technique used to study the bile ducts, pancreatic duct, and gallbladder. If there happens to be a cyst found, a drainage tube may be left in for that. Drugs, morphine or Dilaudid for pain, antispasmodics to decrease the motility and decrease any vagal stimulation, antacids to neutralize acid and decrease production of enzymes, proton pump inhibitors to decrease acid production. Nutritional is very important. Remember, these patients, acute pancreatic patients, would be NPO. In the beginning, we want to decrease the amount of acid and secretion produced. If enteral feedings are begun because the patient needs nutrition and they don't want to use TPN, then the stomach needs to be bypassed and food will go right directly into the jejunum, and this will help from the stomach producing acids and secretions. If, when the patient is on a diet or has the chronic pancreatitis, the diet is increased in carbs because this is least stimulating to the exocrine function. Total parenteral nutrition, or TPN. The purpose of TPN is to maintain nutrition when the client is unable to eat or digest food through their GI tract. This is very expensive and made up per each patient by pharmacy. It requires a central line or a PICC line. It is always an individual line. I mean, they can have a dual lumen, but you can't hang anything else with TPN in the same line. There's no IV piggybacks with TPN. TPN guidelines, making sure that you care of the central line. You want to assess insertion site with the dressing change every week or per policy because it's increased risk for infection, right? Inspect the solution before hanging, making sure that it's the correct solution, checking the additives against the MD order. It's a high alert medications in some hospitals, so some need a second RN check. Making sure that you're checking the expiration date. Usually it's only good for 24 hours. The same with the tubing, should be changed every time you put up a new bag. Observe for cloudiness or floating particulate. Controlling the flow rate of the solution. You don't want to speed it up. It can cause hyperglycemia and possibly hyperosmolar non-ketosis. Don't slow it down because the patient could get hypoglycemia from it. You want to obtain regular finger sticks and checking for hyper or hypoglycemia. Do not stop TPN abruptly. If it has to be stopped, if it runs out, if something happens to the line, well, hopefully nothing happens to the line, but if anything happens to it, make sure that you hang D10 if it's empty, because they need to have the same amount of glucose that they were getting before so they don't become hypoglycemic. Nursing care and management of the pancreatic patient. We will do this in class, so bring your ideas, your thoughts, what you think we're going to need for patient education for our pancreatic patients, what kind of nursing interventions you're going to do for this patient, and be ready to participate. Thank you. See you then.